Good evening to those of you who are on the East Coast, US East Coast, and welcome to the many of you joining us from one of the 7+ different time zones, from Hawaii moving east to New Zealand and Australia, also through the UK and the European Union. This webinar of updates on biomarkers and therapeutics for people with Down syndrome and Alzheimer's disease, what you need to know, is brought to you by the National Task Group on Intellectual Disabilities and Dementia Practices, NTG. I am Kathy Bishop, NTG Co-Vice President and Co-Chair of the NTG Education and Training Committee. It's my pleasure to welcome you and give some housekeeping tips. All participants will have microphones muted and video cameras off for the duration of the webinar. It is not likely that we will have time for questions. However, please send your questions or concerns using the Q&A function at the bottom of your screen. The NTG will be scheduling a Part 2 follow-up to today's webinar. Your questions and concerns will help shape the content of that program, the Part 2. A link to today's recording will be posted on the homepage of the NTG website within 48 hours, and the link is here, www.the-ntg.org. An evaluation link will appear on your screen at the end of the webinar. We encourage each of you to complete this form as we use the information for future webinars and trainings. The NTG also warmly thanks the many co-sponsors who are listed on the screen here. It is also now my pleasure to introduce the moderator for this webinar tonight, Dr. Lucy Ezralou, who is a senior psychologist at the California Department of Developmental Services and chair of the NTG Scientific Research Consultative Panel. Lucy, welcome.
Thank you so much, Kathy, and welcome to everyone to the first webinar in a series of programs planned by the NTG to spotlight advances in the field of Alzheimer's research and future directions for research assessment, intervention, and caregiving. Our panel members will be providing an overview of recent scientific breakthroughs that have the potential to change how individuals are assessed and treated for Alzheimer's disease. Given the format of our program, this is meant as an update and not an in-depth treatment of the topic. We want to thank our co-sponsors for this event, and we also want to thank Dr. Elizabeth Head, who is not able to join us for the program, but who generously contributed to the materials being shared today. Next slide, please. I want to introduce our distinguished panel for today. Dr. Brian Chicoine, Medical Director, Advocate Medical Group, Adult Down Syndrome Center, Park Ridge, Illinois. Dr. Seth Keller, Neurologist, past President of the AADMD and Co-President of the National Task Group on Intellectual Disabilities and Dementia Practices. Kathy Service, nurse practitioner, specializing in gerontological nursing, on the board of directors of the National Task Group on Intellectual Disabilities and Dementia Practices. Dr. Mike Raffi, medical director, Alzheimer's Therapeutic Research Institute, and associate professor of neurology, Keck School of Medicine at the University of Southern California in San Diego. Dr. Huntington Potter, neuroscientist, director, Alzheimer's and Cognition Center, University of Colorado, and Dr. Jim Hendricks, chief scientific officer, LuMind Research Down Syndrome Foundation from Burlington, Massachusetts. Next slide, please. We would like to begin things by having Dr. Chicoine start us off and remind us about the connection between Alzheimer's disease and Down syndrome. So if we could have the next slide, please. Dr. Chicoine.
Thank you very much, Dr. Ezralou. What a pleasure to be here today, and I certainly appreciate this opportunity, and glad we could all be here together to discuss this such an important topic. As mentioned, I'm the medical director of a clinic for adults with Down syndrome in the Chicago suburbs in the United States. And we've served over 6,000 adolescents and adults with Down syndrome and seen approximately 700 individuals with Down syndrome who have developed Alzheimer's disease. So this is something that we see on a regular basis. So thank you to Dr. Head for sharing this slide with us just to talk about the connection. As you can see on the left there, the amyloid precursor protein, the APP gene, is located on chromosome 21 in humans. And APP is a key player in Alzheimer's disease, and it's processed by different proteases resulting in the production of amyloid beta peptides. And since people with Down syndrome have 3 of the 21st chromosome, it is felt that the 1.5-fold overexpression of APP in Down syndrome results in increased production of the beta amyloid, and is a factor in people with Down syndrome have increased incidence of Alzheimer's disease. Studies have indicated that the neuro pathological changes, the plaques and tangles, are present in most people with Down syndrome by age of 40, and essentially all by age 50. But symptomatic Alzheimer's disease is not common before age 40, and the onset of symptoms are typically would most commonly occur in the mid-50s, although they can occur in the 40s. Dr. Resolu, I think you're muted, unfortunately.
The very thing I didn't want to do. Thank you, Dr. Chicoine. So as a primary care physician, you're among the first professionals to see somebody with Down syndrome and suspected dementia. So what do you think are the implications about biomarkers? What implications do biomarkers have for your practice?
So let me give you just 2 brief, quick clinical scenarios that we run across quite frequently. So we'll get a call, or someone will come to our clinic who's a 23-year-old diagnosed with Alzheimer's disease, has had a decline in skills, and someone has given them the diagnosis of Alzheimer's disease. I never say never in medicine, because as soon as I do, I'm going to get tricked, and there will be the one case. But I would say that this is exceedingly unlikely based on what we know at this time, that a 23-year-old has Alzheimer's disease. And then another common clinical scenario would be a 48-year-old presenting with a change in what we call the groove, which is the tendency towards sameness or repetition that is such a common characteristic of so many people with Down syndrome. So as some of them get older and they are developing Alzheimer's disease, one of the early signs for some of our individuals is that this groove is either lost, they are less attentive to details and less don't do as well with their typical patterns of behavior, or that actually increases significantly. They may actually have an increase in the groove, and so these would and that would be a pattern that a change that we see sometimes in our individuals that are developing Alzheimer's disease. It is a lot of people feel that the first symptom of Alzheimer's disease in people with Down syndrome is always psychological or behavioral changes. I don't think it's always, but I think it is a common change. So when trying to diagnose people with Down syndrome with Alzheimer's disease, it's clearly not easy. There are limitations with what we have presently on making the diagnosis. So I certainly want to do a history and physical exam, and then order appropriate lab testing and to assess for a particular pattern of decline that would be consistent with Alzheimer's disease in people with Down syndrome. And then, of course, want to assess for other causes and conditions, and certainly want to rule out other causes of dementia. And we want to look at co-occurring conditions. Some of the conditions may be co-occurring along with Alzheimer's disease. Some may be causing the dementia, and actually the person does not have clear Alzheimer's disease at that point. And so you really want to kind of look and see what we can address in helping the person improve their function. So we know that we certainly want to be accurate with the diagnosis. We do know, unfortunately, that as people with Down syndrome get older, the likelihood that changes are associated with Alzheimer's disease continues to increase. We don't want to just assume, but it certainly a high percentage will be developing Alzheimer's disease as the older they get. So certainly from a diagnostic standpoint, the biomarkers could certainly contribute to helping with diagnosis, but also would be, potentially with treatment then as well. What are the implications for treatment? Unfortunately, the medications we have for Alzheimer's disease in the non-Down syndrome population at this time, at least in a Cochrane review several years ago, were not found to be beneficial in people with Down syndrome, and our clinical experience would be the same. That really, I do not find them to be beneficial. In fact, many times when people have been started on them, I find that they complicate the treatment of the individual, because they will often have behavioral or psychological side effects, and so we end up stopping those because of those changes.
Mm-hmm.
So certainly patterns of biomarkers and various blood and CSF testing that are being studied with people with Down syndrome and those with Down syndrome and Alzheimer's disease hopefully will have real benefit as far as both assessment and treatment.
Good. Thank you, Dr. Chicoine. Next slide, please. And I think you began covering this in terms of the value of the biomarkers, but what about the new therapeutics in assessment and treatment of Alzheimer's disease for people with Down syndrome?
Again, so our present treatments are certainly pretty limited for treating Alzheimer's disease in people with Down syndrome. So really the treating the co-occurring conditions are really what so much the treatment is about. And again, in my experience, or in our experience, the psychological or behavioral symptoms are most commonly the most challenging. And so, how can we improve the treatment of those? So as we go forward with looking at biomarkers, certainly not only the implications for diagnosis, what can we do to improve the diagnosis of Alzheimer's disease in people with Down syndrome, but in some ways, at the moment, with such a high percentage developing Alzheimer's disease, there's some degree of sense that there's a certain degree of inevitability, and so we want to be aware that these changes may well be associated with Alzheimer's disease. So even in some ways, even more importantly than the diagnosis in our present state, because we do not have a treatment for Alzheimer's disease specifically, in some ways that more importantly would be to, how can we assess for other co-occurring conditions or contributing conditions, and based on the patterns of biomarkers, will there be a way to actually improve treatment for those conditions? So, for someone with one pattern of biomarkers, for example, might there be more implication for treating the co-occurring depression or behavioral changes with certain treatments versus a different biomarker pattern that might lend itself to a better treatment for these problems with the different medications or whatever. So going forward, at least in the primary care arena, treating the symptoms in some ways is going to be more important. And how can these biomarkers and other assessments improve our ability to treat these co-occurring conditions, which are so challenging for the families, while in the meantime we're still working at developing medications or whatever that will ultimately hopefully cure or arrest or even prevent Alzheimer's disease in the future.
Thank you so much, Dr. Chicoine. Next slide, please. I would like to call upon Dr. Keller. And Dr. Keller, what are some of the changes in assessment and treatment that you see within your practice as a neurologist treating people with Down syndrome and suspected dementia? And we can go to the next slide as you answer that question.
Right. Yeah, thank you, Lucy, and thank you for hosting this event. The neurologist, from a perspective of where the role is just in general, is they're the quote unquote specialist that is trained in their practice of neurologists to understand a lot more about what dementia is, the diagnosis, the testing, the therapeutics. So the training of neurologists is that they have gone through extensive training within dementia and differentiation of it. So really what we do now, and thank you, Brian, for leading us off, because I think that's a great segue, is right now, as Brian was describing, right now in light blue, the assessment is the history, and Brian mentioned that, and we definitely will also agree that excluding everything now is really important. It can't be assumed that it's dementia. And that's huge, because I think right now, before biomarkers, which is what my other colleague going to be talking a lot about, is it's a guesswork and it's empiric. We think what it is. Brain imaging often doesn't really help, but that's done. And a tool that we use in the NTG called the NTG EDSD is a tool, an assessment tool that people use for assessments. The future is really going to change in terms of the accuracy of the assessments by the biomarker. So we're really going to know in the future how the accuracy is really going to be so much more than we do now. All the other aspects remain the same: history, excluding, imaging, assessment tools are going to be there. Then the therapeutics, again, are also what we do now. Health and wellness and promotion and mitigating circumstances. I know that one of my colleagues will talk about that somewhat. Mental health supports, and then definitely research trials and some of the other medications that Brian had mentioned about. So I guess some ambivalence about what they may do, but definitely in the future, again, things are really going to change, because the therapeutics that are, again, my colleagues are going to be touching upon in this talk, the affecting upon the pathology in Down syndrome or Alzheimer's in general, beta amyloid and tau and the neurodegeneration are really going to be important, but definitely aspects of research. And so really things are going to change. But Lucy, as we're going to be talking about, I know in the next question, and I want you to move on to the next question, because that's really the next big point.
All right, next slide, please. And so the next question is, what activities do you think are necessary to support the changes in assessment and treatment that you see coming within the field?
Yeah, I mean, this is everything, because really, even though the research is going on, but if the practitioners, primary care neurologists, others aren't getting the knowledge and education or the awareness of it, it may not go anywhere. So really what has to change and move the needle, aside from the wonderful research, is really education and training and all this work. And just like we're doing this webinar today with organizational support and the different organizations that are involved and all these wonderful people coming on, is working through the multidisciplines that are going to be involved: primary care, specialty care, supportive care, caregiver supports and involvement. So Lucy, this is something that we in the future, with all of our friends and partners on this call who are talking and those that are listening in, working with them and all, is going to be great. So this is really what I wanted to get across, but I wanted to leave time for my other colleagues to really go into more details. Thank you, Lucy.
Okay, thank you. All right, and next slide, please. Thank you. All right, so I want to invite Kathy Service, and I want to ask her, as a nurse practitioner who works with individuals with IDD and their families, what are the concerns you hear from caregivers regarding receiving a diagnosis of Alzheimer's disease? I'd like to understand what you're hearing kind of in the field, so to speak. And next slide, please.
Yeah, please. Thank you. Well, I mean, before I answer this, I know we're talking about biomarkers, but what I have to say has a lot to do with any medical treatment, and such as aducanumab, and for research. So, I mean, quite honestly, most of the caregivers, whether paid direct support providers or unpaid, family, are in the thick of the moment and are quite concerned more on day-to-day struggles, really. Even something like, how can I get my son out of the car? And giving the time frame, at least with what we know about aducanumab, when it's found to be the most beneficial, most of the people that I've had connections with are past that time frame. And the lament that I really hear from people is, where can I get help in trying to figure out what's going on with my family member? And even if we bring up, the medications, people say, well, if you spend so much, how can all that money go into medicine and I can't get money to help with my caregiving? So So that, I mean, getting back to getting help when they need help in terms of diagnostics. And so finding practitioners, finding people who are close by, and even then, if you have somebody, even getting to bringing somebody who may be in behavioral stress to any of these assessments can be really either traumatic for the person and really exhausting for the caregivers. And there are very few places, I mean, quite honestly, in this country that have the expertise to be able to, and time and interest to be able to work and help people diagnose and even manage and support people with with Down syndrome and dementia. So really, this is key. So even and after the fact, what do we do later once they've been diagnosed? So, and this picture this looks like a real simple picture. There's Ellen getting her EEG, but my friend and colleague Jane, whose sister shared this with me, says, you wouldn't believe all the effort that went into even getting her to get to this point in terms of getting the EEG. So I think we don't often understand that how much work and effort it goes in for family caregivers and direct support professionals into being partners in terms of some of the research and some of the treatments. So, and as one family member pointed out to me, is that not everybody has the ability to tolerate diagnostics. The other issue is in the quest for dementia diagnosis, and I think both Dr. Keller and Dr. Chicoine alluded to this, is this whole notion of diagnostic overshadowing. And I find that that's a real issue for people, especially for people with Down syndrome. And and I just want to reiterate what was said, is that a gerontological nurse practitioner, and this I hear all the time from the geriatricians, is that dementia is a diagnosis of exclusion, rule out potentially correctable conditions, and people, as we know, have a number of possibilities, especially people with Down syndrome, and then at least treating, assessing and treating empirically and weighing risk and benefits of treatments and interventions.
Mm-hmm. Next slide, please. So, Kathy, what concerns do you hear from caregivers regarding their day-to-day caregiving experience? And what can we tell people about approaches that might help now?
Yeah, and this is hard because we're talking about something really scientific, but this is going down to sort of like the basics of what, trying to care for people. And one of the things that I really, and people who know me will say, and it's like I'm in the groove that Dr. Chicoine talks about, that people are living with dementia. So we need to let them and try to help them have a good life. And we know that, I want to also stress that well-being is a goal of dementia care. And that's even stressed in that Lancet article that I posted on, that I have down low in the slide. And, caregivers, feel quite hopeless and feel there's nothing they can do. And one of the things that I always tell people is that, there is a treatment, and the treatment is you, and how we take care of ourselves and what we learn about dementia is the key for all of us overall to be better and to have a good life. So, there are a number of non-pharmacological interventions that are in the literature. There's even a website that talks about, that lists all these, and a number, not all of them, but there's a number of them in a website that has to do with, dementia caregiving. There are also the things I also want to stress is about brain health and the 6 pillars of health. And even though, granted, keeping healthy, doing all of these things are not cures for dementia, but by keeping ourselves overall healthy and feeling good, will make ourselves feel better, whether we're caregivers or whether the individual, and may cause less behavioral distress and cause less issues around hospitalization and whatnot. So those are the things that I want to stress, is taking care of ourselves, all of ourselves, as best as we can. And it's these kinds of interventions such as movement, getting stress management, social interaction is key. And that's been really tough during these times. the other thing I wanted to say that it could be, the strategies, I mean, you can get help from a lot of, and there's a lot out there. And, I found over time that really essentially there's so many programs on dementia, providing care for dementia. And, basically the goals are the same, but for people with Down syndrome, the strategies to reach these goals and to whatever the goals are may be modified, because there are some differences that we need to know and realize that people are in different situations, whether in a group home residence or family residence. So I think, modifying the strategies for supporting people. The other thing that I wanted to say that it can be overwhelming, in terms of navigating all of these resources. And that I wanted to say that, every state is different. So you really need to look at your aging system. There may be some resources there. The Alzheimer's Association may be beneficial. Some states have really robust DD services in place. The NTG's website has a lot of information. So I think you can look online and find things. And I wanted to kind of say is that, there's the National Family Caregiver Support Program, and that's available through your area agency on aging, and they may be able to provide some supports for you or help you kind of figure out. But again, finding people and finding reliable resources will be key in this whole work. So I think that, and I spoke about the education earlier, finding people that you can know and trust and be able to help you through the group. And the other thing I want to add is that looking at the support groups in your area, we don't, it's really unusual. Most of the times I found that families and caregivers to go to support groups in the general population can not quite be the same. So I do know that the National Task Group has an online support group that's been going on for years, that were started by J. Dean Ransdell and Mary Hogan, both family members, and has spawned some state support groups. And that information's on the website. So finding people you can trust, and don't be afraid to ask for help, and take the time what you need. And for families to also, finding, and for caregivers, it can be difficult, but finding those people who can support you and understand what you're going through is key. And one of the things that I have found, and I always stress, is that you, as family members, as staff, as people, you're our best teachers. So let us know what we can do to help you.
Thank you, Kathy. So one of the things I just wanted to go back and to say about the Healthy Brain Initiative, which does focus on the 6 pillars of health. So if any of you are interested, there are actually modules that go along with the Healthy Brain Initiative program, which will teach you about exercise, stress management, nutrition, all the things that we know have to do with lifestyle and can be helpful to people at any age in terms of healthy brain aging, and for caregivers as well as the individuals who are cared for. So thank you, Kathy. If we can have the next slide, please. So I want to invite Dr. Raffi to talk a bit about, we talked about the biomarkers. So we'd like to hear more about the new therapeutics, particularly aducanumab. So can we have the next slide, please? And Dr. Raffi, if you would enlighten us about this.
Thank you, Lucy, and thank you to the NTG for organizing this important meeting. I was asked to give an update on aducanumab in the context of immunotherapy. As you'll notice, aducanumab, the name of the drug, it ends in 3 letters, MAB, and that means monoclonal antibody. And so aducanumab belongs to a group of medications that are monoclonal antibodies. And in this case, this drug targets that beta amyloid that Dr. Chacoin described earlier. It's thought that beta amyloid is a key driving factor in Alzheimer's disease in the general population, as well as in the genetic populations who have autosomal dominant mutations that lead to early onset Alzheimer's disease, as well as in individuals with Down syndrome who have an extra copy of the APP gene that leads to overproduction of beta amyloid. Aducanumab is one of actually many drugs that are immunotherapies. As you're probably familiar with drugs such as Humira and Rituxan and Herceptin and Avastin. These drugs are given typically as monthly infusions, and they have various targets that they go after to eliminate, using the immune system's power to remove some target that shouldn't be there. In the case of aducanumab, that target is beta amyloid, and aducanumab is the first drug to receive FDA approval. And in this slide, I will go through what type of approval that is and how we are at this point. So aducanumab is a drug that has been tested in 2 phase 3 trials. Emerge and Engage are the name of those trials. However, both of those clinical trials, which were conducted in individuals who have either mild cognitive impairment or early dementia due to Alzheimer's disease in the general population, both of those trials were stopped early for what is called futility. In this case, futility is a statistical term where the study is thought to not meet its outcome. The hypothesis is that this drug given once a month should remove beta amyloid from the brain and therefore should stabilize cognitive decline, which is part of Alzheimer's disease. And many times drug companies will take a look at the data as the trial is being conducted. An independent group will take a look at the data and see whether there is any chance that there is a futility, that this test would actually be futile. And these trials each had thousands of participants in them. And when the data was pulled to do the review for futility, during that interval, participants continued to go on to their study visits. So it took about 3 months until the drug maker decided, yes, the results appear to be futile, and therefore we are going to stop these studies. And after they called off the 2 studies, they saw the data that came in during the 3 months while participants were still coming into the clinics while they were making their decision about futility. And it turns out that one of those trials would have been a positive study, and one of those trials would have been a negative study. And the company, Biogen, which created this drug, has different explanations for why this happened, why there is a discrepancy between the 2 results of the 2 studies, and also why that the studies were thought to be futile in the beginning. As you can see, both of these studies, particularly the Emerge study, had drug exposure, and the Emerge study in particular had a much higher drug exposure. And that is thought to be one of the reasons why that study was positive. Now, these studies, they measure amyloid in the brain, and they look at whether the drug removes amyloid in the brain. They also measure tau in the brain. That's another key hallmark of Alzheimer's disease. And certainly amyloid is removed with this drug from the brain. And certainly there is a signal that tau seems to be diminished in its accumulation in the brain. But these studies are done in the general population. The measures that they use to look at cognition are developed specifically for the general population and not in persons with Down syndrome. When the data was submitted to the FDA, the review was split. The clinicians on the advisory committee who reviewed the data said that this is favorable. The statisticians on the committee said that the review was unfavorable. And the overall vote of the advisory committee to the FDA was unfavorable. Now, there have been many times where the advisory committee gives a recommendation and the FDA will determine that they will go along with it, but there have been times where the FDA has not gone along with the advisory committee. And in this case, the FDA determined that they would not go along with the advisory committee and instead grant an accelerated approval. This is different than a full approval, and I'm just going to read for you what an accelerated approval is. This is a pathway that's available under federal law when a drug intended for a serious disease is expected to provide a meaningful advantage over available treatments. or no treatment at all. A drug may be approved under this pathway when it is shown to improve a measure of a disease and when it is reasonably likely that this measure predicts clinical benefit. Note that the law says reasonably likely to predict and not certain to predict. In other words, accelerated approval was designed for situations in which there is residual uncertainty about clinical benefit. What does this mean for aducanumab? This means that the measure of disease that the drug impacted is amyloid in the brain. It clearly removes amyloid in the brain. And it is believed that removal of amyloid, which is so critical in Alzheimer's disease, that removal is reasonably likely to predict clinical benefit, which was not shown in those trials. However, there is no treatment that impacts Alzheimer's disease as a disease-modifying drug. And so for that need for therapy, the FDA has given this accelerated approval, which means that the drug company now has to run a phase 4 study. In this case, the drug will be made available, but it will require the drug company to collect data on clinical benefit. Otherwise, the drug will be removed from the market. Now, the major issue with the approval of the drug is not just that whether or not the drug has clinical meaningfulness, but indeed there is a significant cost associated with this drug. As I mentioned, it's a monoclonal antibody that is given as a once-a-month infusion, just like Humira and Rituxan and Keytruda and all of these other incredible drugs that are quite expensive. And the Centers for Medicare Services are reviewing all of the data, including cost-benefit analyses, to determine whether this drug should be covered by Medicare. Again, this would be specifically for the general population, since that's the population that these clinical trials were conducted in. And that decision is expected sometime at the end of April of 2022. In addition, CMS will likely also be deciding whether or not they will cover the cost of a PET scan that is necessary to confirm that there is amyloid in the brain in the first place, so that the diagnosis is confirmed in the general population before a medication such as this is prescribed. Next slide.
Yes, thank you. And so, Dr. Raffi, what has been some of the preliminary thinking about immunotherapy for Alzheimer's disease and Down syndrome?
Right. So the drug in aducanumab has not been tested in individuals with Down syndrome. And so there have been appropriate use criteria published about who should get this medication, not just in the general population, but what stage of Alzheimer's disease. And the formal recommendation is that it should not be prescribed for individuals with Down syndrome at this time. There are safety studies that are needed, dosing studies that are needed in order to extend the label into persons with Down syndrome. In addition, there will be questions as to what stage of Alzheimer's disease in Down syndrome should this drug be offered at? Should it be offered at the later stages, at the minimally symptomatic stages, or should it be given as a preventative, knowing that so many individuals with Down syndrome are at such high risk? And what age should the treatment start at, and how long should it be given? In addition, these drugs all have side effects, and one of the side effects with aducanumab are changes on MRI, oftentimes completely asymptomatic, meaning no symptoms, but they can be visualized on an MRI. And so the question is, if we want to be able to capture those changes, and an MRI is required after 12 weeks of being on this drug, we want to make sure that individuals with Down syndrome who would be prescribed such a drug someday would be able to tolerate MRIs. And would they be able to tolerate monthly intravenous infusions? So these are big questions that need to be answered, but they are answerable. Label extending studies have been done for other drugs in the pediatric Down syndrome population, and similar studies can be designed for immunotherapies for adults with Down syndrome who may be at risk for developing Alzheimer's disease. So currently, the recommendation is that we should not prescribe aducanumab for individuals with Down syndrome until safety studies are conducted, until label extending studies are conducted, because the label currently indicates that it's for use in Alzheimer's disease that is in the mild cognitive impairment or in the mild dementia stage in the general population.
Thank you so much, Dr. Raffi. Next slide, please. I'd like to call upon Dr. Potter. And Dr. Potter, would you please share with us your current research? We can have the next slide too.
Thank you very much, everyone, for coming and joining our webinar, and thank especially Michael Raffi for giving a great introduction to the new drug aducanumab. To reiterate, these are the 5 drugs that are currently FDA approved for treatment of Alzheimer's disease in the typical population. The first 4, Namenda, Aricept, Razidine, and Exelon, have only one purpose, which is to help neurons in the brain communicate with each other a little bit better by either helping the receptor on the receiving nerve cell or helping the neurotransmitter communicate with that nerve cell. They don't affect the disease process itself, and they have very minor slowing of the course of Alzheimer's disease cognition in the typical population, and have been used to treat people with Down syndrome at the individual level. The new drug aducanumab, as Dr. Raffi indicated, is a monoclonal antibody, which helps the brain get rid of amyloid, and is shown in the bottom, indeed, 1 year of treatment, and the amyloid is basically gone. But the problem with all of these drugs from a clinical point of view is that they don't actually improve the memory or cognition of people with Alzheimer's disease or with Down syndrome. So we took a look at this situation, decided to take a different approach, still an immune approach. It turns out that people with rheumatoid arthritis tend not to get Alzheimer's disease. And Tim Boyd, my graduate student, and I started to look at why. To make a long story short, we focused on a particular natural human protein called GM-CSF. Stands for granulocyte macrophage colony stimulating factor. And I promise there won't be a test at the end of the webinar for you to remember that. But granulocytes and macrophages are like little Pac-Men. They're white blood cells that roam around the body and get rid of things that aren't supposed to be there. So we hypothesized that GM-CSF might help the brain get rid of amyloid. The animal models, both animals with Alzheimer's disease and amyloid pathology, and also very recently, animal models of Down syndrome that don't even have pathology, were all benefited in their memory by treating with GM-CSF. That initiated a clinical trial, which has just been finished, in which we treated for 3 weeks only, 5 days a week, people with mild to moderate Alzheimer's disease of the typical population. And the results are encouraging. Next slide, please. On the top is the mini mental state exam scores over the period of the trial, 3 weeks of treatment, and then 2 follow-ups, 45 days and 90 days later. And as you can see, the blue line improves compared to its baseline. Those are the people who got GM-CSF injections every day, 5 days a week. And then the red line are the people who got ordinary salt water. And you can see that, previous slide, please, that even at the 45-day follow-up, there was a benefit cognitively to the treatment of GM-CSF. The bottom slides are complex, but for those of you who are scientists, they are blood biomarkers of the neurodegeneration in the brains of these people, and they also improve toward normal with the treatment of GM-CSF. And as Dr. Raffi indicated, brain ARIAs, or bleeding and hemorrhage that can be seen, and swelling that can be seen on MRI, we did not see that with GM-CSF. Next slide, please. Finally, we've started a new 24-week phase 2 trial of GM-CSF. It's been funded by the NIH, the Alzheimer's Association, the Global Down Syndrome Foundation, and we've just been awarded a specific grant to study GM-CSF in young adults with Down syndrome, even before they get any Alzheimer's disease. So it's a promising new drug, and it's one of many that many researchers around the world are developing to treat Alzheimer's disease and potentially in people with Down syndrome. Thank you very much.
Thank you, Dr. Potter. Next slide, please. At this point in time, we're actually heading towards future directions, and I'm going to ask Dr. Hendricks if he would give us his thoughts about that. To begin with, the next slide, Dr. Hendricks, why should we care about biomarkers?
Well, thank you very much for the opportunity to be part of this very distinguished panel. This is great people on this panel and really great information. So I'm with the Lumine IDSC Foundation, and I'm really thrilled to be here. So biomarkers are really exciting and interesting. The research in Alzheimer's disease is, from the outside, seems like it has made no progress in 20 years. It's been almost 20 years since the last drug was approved by the FDA for Alzheimer's disease before we had aducanumab approval this year. But we've made amazing progress in the research of biomarkers, and biomarkers tell us a lot of things. So one of the things that we've learned about Alzheimer's disease by studying biomarkers is we know that the brain starts to change 10 to 20 years before symptoms. That is, that the formation of these amyloid plaques, which you see on this slide here. And I should mention, I'm sitting in for Dr. Elizabeth Head today, who couldn't make it last minute. She prepared these slides, and it was really a shame that she couldn't be here, but I'll try to do her slides justice. But in Down syndrome, we know that by age 40, almost all people with Down syndrome have these neurofibrillary tangles and from the tau protein, and also there's plaque from the amyloid, and these are really the signs of Alzheimer's disease. In fact, Dr. Alzheimer's, who looked through a microscope at brain tissue over 100 years ago, that's what he saw. He saw these plaques and these tangles that are associated with Alzheimer's disease. So now we can detect these changes through brain imaging, like PET imaging, or through the analysis of cerebral spinal fluid, and more recently with the advent of blood-based biomarkers. So it's a really exciting time. Next slide. So there are several reasons why we should care about these biomarkers. One is when we think about treatments, it's really important that we know who is getting Alzheimer's disease, and if the particular therapeutic that you want to give is going to attack the disease in the way that you want to. For example, in the case of aducanumab in the clinical trials, the sponsor Biogen made sure that everybody in the trial had evidence of amyloid plaques based on an amyloid PET scan. So they used the biomarkers not only to track to see if the drug was working and removing the amyloid from the brain, but to make sure that the right people were in the study. So I think that that's an important distinction with that drug and that drug approval compared to previous drugs. Using the biomarkers, I think was the difference between an approval and not an approval in this particular case. So it's really important, and I think that in the case of Down syndrome, people are on the path toward Alzheimer's disease because of genetics. The biomarkers will help us in terms of the timing. We'll know when people are starting to progress. We'll know what their issues are, and that is important for the second big reason is to monitor people and monitor their health. And it's also important to look at the biomarkers that are associated with adverse events or side effects. And Dr. Raffi mentioned ARIA and how we have to use MRI to know if people are having a negative reaction to the immunotherapy in the case of aducanumab. And it's really important that people are able to be monitored using this imaging technology. That if at some point in time we are able to offer this drug or drugs like it to people with Down syndrome, the people who are on the drug have to be able to tolerate not only the infusion of the drug, that is a shot, a regular shot in the arm that takes a long period of time, but also to be able to sit still in a very confined space, in a noisy space, with their head very still, to be able to make sure that they don't have micro bleeds or swelling of their brain, because most of the cases of ARIA in the clinical trials that Biogen these people did not have symptoms. So they were able to catch the side effects before anything really serious happened. And what they did is they would either remove people from the drug therapy or they reduced the dose. And that resolved the ARIA, that is, the ARIA went away. So it can be serious if not caught, but if caught, it can be managed. So that's why it's really important that we look at biomarkers.
Yeah, thank you. Next slide, please. And Dr. Hendricks, what's important for us to know about clinical trials for the new therapeutics?
Yeah, so I think, and again, Dr. Raffi kind of touched on this, that what we need now that we have this new drug and other drugs that are in the same class that are coming, several other companies have announced that they have similar drugs that they're going to take to the FDA for review. We need to make sure that our population, the Down syndrome population, can use these drugs, that they're safe and effective in our population, and that means we need to do trials. And I think the first trial really that should be done with Aduhelm, and should be a safety trial to really look at the incidence of ARIA. We know that this drug causes ARIA, but will it increase the risk of ARIA in Down syndrome? We know, unfortunately, that because there's so much beta amyloid in the blood vessels of the brain of people with Down syndrome, as they get older, they have a higher likelihood that they will get microbleeds in the brain. And this is in the absence of any drug. What we don't know is, will adding Aduhelm or a drug like it increase the risk of these microbleeds? Will it make it worse? So we need the data. We need to test this. And so we're hopeful that Biogen or the NIH or other groups will mount this effort and do a safety study on this drug, and make sure that we are that if physicians and families want to take advantage of this new therapy, that they can do it with the full knowledge about the safety, the risks that are involved. Because we right now, as Dr. Raffi said, the recommendation is not to use this in the Down syndrome population because we just don't know.
So next slide, please.
So let's talk. So this is, clinical trials with adults are really needed. So to establish safety. So on the next slide, I want to talk a little bit more about what are the other what are barriers that we see to clinical trials in Down syndrome, and how does the experience differ between sporadic AD, that is in the general population, compared to Alzheimer's disease. So next slide. So in 2020, Bluemind worked with the National Down Syndrome Society and the Eli Lilly company to conduct some focus groups and interviews with caregivers of adults with Down syndrome. We're going to get their view on clinical trials, on how do you, on recruitment, and I want to share with you some of the things that we learned from that effort.
Next slide, please. Thank you.
So these are just some overall qualitative findings, and this is actually consistent with some of the survey work that we've done on research attitudes at Remind IDSC. So first question is, would you support your loved one with Down syndrome participating in a drug clinical trial? So only 13% said yes. 68% said only if it benefits my loved one. So that's a really difficult question to answer when you're trying to test an experimental therapy. So you don't really know. That's why you're doing the trial. So potentially it could benefit, but it also could potentially harm. So that's what we don't know. That's what we have to do the research. And almost 20% said absolutely not. They would never allow their loved one to be in a drug trial. The next question is, would you support your loved one with Down syndrome participating in a lifestyle clinical trial? So testing things like exercise or a specific diet or management of maybe other lifestyle characteristics like social engagement or educational activities, or maybe management of blood pressure, for example. These will all be examples of lifestyle trials. And 72% said that they would agree to that. 8% said if it benefits others, and 10% said if it benefits their loved one. So at least for this one, nobody said no. And then, would you support your loved one participating in a natural history study? A natural history study is just an observational study. You don't actually give a drug or a treatment. You just observe people over time and you record their medical. And a smaller percentage had other chose the other options. So I think as you can see here, many people, many caregivers with Down syndrome are risk averse. They don't want to put their loved one at risk, and that's certainly understandable, especially for possibly for parents who spent the entire life of their loved one, advocating for them, protecting them, making sure that they're safe. So, but the last question is, do you want to see more research for people with Down syndrome? And 100% said yes. So that's the conundrum we're in. People are afraid to participate in trials, but everybody wants to see more research done. So we really have to work hard to convince people that this research can be done safely and appropriately in the Down syndrome population. Next slide. Yeah. So this was just an analysis of the same study where we compared the what's called the late onset Alzheimer's disease population, that is the general population with Alzheimer's disease, to the Down syndrome population. So for the general population, caregiving is a new role. So a family member, maybe it's a spouse or an adult child, they're suddenly thrust into the role of caregiver as their loved one begins to progress with symptoms of Alzheimer's disease. But in the Down syndrome population, as I think everyone knows, caregiving and advocacy is really, lifetime identity. People have spent decades in this role, and they're very, very tapped in to the role of a caregiver and an advocate for their loved one with Down syndrome. So in Alzheimer's and sporadic Alzheimer's disease, proactive patients and caregivers are seek out the top specialists for memory and cognition, and that includes clinical trials. While in Down syndrome, Alzheimer's is a top concern and a first priority for healthcare providers, is really Down syndrome knowledge and experience. So you have to find people like a Dr. Keller, who really understands Down syndrome and Alzheimer's disease, Dr. Keller and Dr. Chacoin, who really understand this. And they're unfortunately few and far between. And we need more folks like them, because there's just not enough great physicians like the two on our panel today. And Alzheimer's disease diagnoses are often avoided in sporadic AD. People are afraid of it. It's a disease that is often whispered. Nobody wants to admit it. Nobody wants to admit that their spouse or their parent is starting to slip, and the person who's got it doesn't want to admit that they're noticing some changes. And so they often delay in the diagnosis. In Down syndrome, as was mentioned by Kathy Service, that this somebody is Alzheimer's disease, or as Dr. Ciccone pointed out, somebody comes in their 20s and with a putative diagnosis of Alzheimer's disease. This is not, this is often a problem in Down syndrome because people know that the rate of disease is high, but if any change occurs in an adult, they automatically assume Alzheimer's disease, and that's not often the case. So we have to make sure that we have education for our primary care physicians to understand how to diagnose this accurately. And the other thing that's different is the clinical trial participants in sporadic AD often know that or often believe that the trial will help them, but they often know that most likely it's not going to really help them, but it might help their children or their grandchildren. And so they are willing to participate in a trial, even though that it may not help them. But as I mentioned before, in Down syndrome, often because caregivers are the ones who are going to decide if their loved one's going to participate, they really want to know that the benefit is going to be to the individual with Down syndrome for their loved one, and benefit to the community at large is not top of mind for them. So those are the kinds of differences that we observed from the work that we did. So next slide. So some other recommendations. So this is kind of recommendations to how you run a trial, and I'll just go through this quickly. But it's really important that the clinical trial staff treat the people that come in with a good customer experience, just like if you were to go into any business, you want to be treated well and treated nicely. So, make sure that everybody that's participating clearly understands the expectations of the trial, but also the expectations of participating in the trial. What are you going to be asked to do? Why are you be asked to do these things? And what's the purpose? Make sure that there's no surprises. Make sure that everything's clearly laid out, that everything's explained as best as possible. And I think that this goes also as much as you can for the participant with Down syndrome. Make sure that they have an understanding of what they're going to be asked to do, and they may not be legally able to consent for their trial. We strongly believe that everybody who is participating in a trial should assent. They should agree. It's common courtesy to ask permission before you stick a needle in somebody's arm, or ask them to sit still for a test. Want to make sure that you have a good personal connection with the person with Down syndrome and their caregivers. Having that good rapport, and that can happen over the phone, it can happen in person. It's just very important for good called the seekers. Seekers are often, maybe some of you that are on this webinar are seekers. You're seeking knowledge, and often people in the Down syndrome community turn to you for advice. They turn to you for information. And so if you're doing a clinical trial and you can engage seekers who are, I guess in the term of the internet or social media, these are the influencers, people who influence the Down syndrome community. This will help improve the recruitment for the trial. In the next slide. So the other challenge for Down syndrome trials in Alzheimer's disease is just identifying the. Thank you. Okay, thank you. So we know that there are also generational differences. So it's a challenge if somebody with Down syndrome is 50 and they have parents who are in their 70s, and asking them to do one more thing. We want you to participate in the clinical trial. This is a lot of extra work on top of everything else they may be dealing with. So we have to deal with these generational issues too, and really try to find ways to lower the bar. We have to find determine what state and other organizations that can support and help play a role in the trial. So the ARC, Special Olympics, other places that can help to communicate about ongoing trials. And as I said, find a role for the seekers, the people who are influencers and play a leadership role in the Down syndrome community. And gain a deeper understanding of the primary care role, especially for the older parents who are caring for a person who may be in their 50s. And then, we want to get we want to get the people who have participated in the trials to share the experiences that with others, and hopefully those experiences are positive, and that will bring other people in, and gaining and sharing what the benefits are for being in a trial. So things like really getting access to world-class healthcare is one of the benefits of being in a clinical trial. So those are kind of the main things that we want to do. And we want to explore opportunities to bring people with Down syndrome associated Alzheimer's to the trials versus them having to travel to a clinical trial site. So anything we can do to lower the barrier to participation. So I think I have one more slide, and I just want to leave this with you. So I know that many of you have fought long and hard for inclusion, for the issue of inclusion. You fought for educational inclusion. You fought for employment inclusion, and those have made huge differences in the quality of life for people with society. Having interacted with people with Down syndrome, I can tell you I'm happy every time I get to meet somebody, and I would be, our world is a better place having them in our schools, having people with Down syndrome employed. I think that inclusion has been amazing for everyone involved. We want to get medical care. We want to have better access to better quality medical care. As I said, like the kind of care that can be provided by the experts on this panel, we just need more of it. Now we need to fight for inclusion in clinical trials. We know that, Alzheimer's disease is a huge problem in the Down syndrome population, yet very few people with Down syndrome have ever been in an Alzheimer's trial. And as was mentioned by Dr. Raffi, nobody with Down syndrome was in the aducanumab trial. So that's something we need to change. We need to fight for that inclusion, but it has to be a team effort, and it has to happen together. We can't just ask the pharmaceutical companies to do it. We have to be willing to step up and participate, and that is going to take a team effort. So you need to get off the bench, and you need to roll up your sleeves and sign up for trials. And anything that is an ethically run trial with the proper controls that I mentioned earlier, consider those for your loved one. So with that, I'll stop. Thank you very much for the time.
Thank you, Dr. Hendricks. So what I'd like to, because we're in a really fortunate position of having some time left over, I'd like to circle back first to some of our panelists who've put some things in the chat, and I wanted to ask them just to elaborate on it. So Dr. Keller, I noticed that you had something in the chat about Aricept and Namenda. Would you like to talk about that a little bit?
Absolutely, and it's very relevant to therapeutics for Alzheimer's then and now, and what the future would be. Is that for decades and a lot of decades, the only medication we actually ever had FDA approved was the medications Aricept, Exelon, Razodine, Namenda, and these were described quite nicely by Dr. Potter and what they really do. At best, even for people, neurotypical non-Down syndrome or non-IDD people, they were even marginal at best. And when the drugs were given, this is before biomarkers, we were just giving them priority, almost like anyone that's quote unquote has dementia, quote unquote has Alzheimer's, and they basically were given out, and it was really a hodgepodge and a mess, and that was really the so-called status quo of how we medically treated people. There were limited studies that have occurred though in people with Down syndrome who've aged with decline, suggesting they had Alzheimer's, and limited studies did show maybe in some of the medications, maybe Aricept, maybe it could and I'm kind of giving you this whole vague story about this. And the other problem also is that how do we gauge benefit? How do we really know the value and benefit of these medications if there's marginal best and you're not curing anyone, there's decline? So my rule of thumb has always been, and I've been doing this for many years as a neurologist, if I'm going to give one of these medications, even drugs, and even in drugs like aducanumab or any other future medication, is gauging benefit of the value of knowing if these things work, and assessing people aside from biomarkers, which is looking for a reduction of the amyloid or tau it may be. We have to be able to have some kind of tool or scale or measurement that family members, organizations, caregivers can give feedback to the practitioner a lot. So I took a question about Aricept and turned it into an assessment question, but that's where we're at.
Yeah, that's good. Dr. Chicoine, thank you, Dr. Keller. Dr. Chicoine, I wonder if you had anything that you wanted to add to what Dr. Keller just said in terms of your clinical practice, your thoughts about Aricept and Namenda.
Yeah, I just have not found them, as Dr. Keller mentioned, marginal in the non-Down syndrome population, and I would agree that's generous in our patients. Frankly, I don't really find that they're beneficial, and I've just seen too many side effects, so I tend not to use them.
Yeah, and many times, Brian, I think what it is, we're desperate. I think what tragically about all this is there's a level of tragedy or desperation when the individual, the family member, the person in front of you with them is progressing. And as we're talking about Alzheimer's disease, we know what is going to happen with the diagnosis in months and years to come. It's a tragic situation. So there becomes a level of desperation of, you got to do something. There's something you got to do for me. And that also goes to the question of nutrients. And aside from medication, like what we're talking about, well, I'll use like the nuance of like Prevagen. I'm sure you've all seen TV commercials of Prevagen, which is this like over-the-counter medication on the shelves of most pharmacies that anybody can pick up, and you see the ads that talk about it. And none of these have ever had any proof, but these are nutrients or supplements that some manufacturer would put out there, and they have testimonials on the TV that show it. It's nonsense. To me, it's like snake oil. I think it's always a tragedy. But again, not only pharmacologics like the Aricept and all these, but also these nutrients and supplements.
That you had after your presentation.
Yeah, I kind of, I felt like I babbled quickly through because I felt sort of trying to get through everything. But honestly, when you look at that Lancet article, it was incredible that we know that physical, by keeping physically well-being and physically healthy, it has implications for our brain health and our overall well-being. So, if you really look at, getting your vaccines, preventing, flu can be deadly for somebody with dementia. So some of these other kinds of activities, eating well, even after the disease, really has a lot of implications for having a well-being and having you're living with a disease. So, it's also, I understand, Seth, what you're saying about the tragedy, but that, and it is hard. I'm not going to deny that, for people. I'm on, I kind of help now to facilitate that support group. And it can be really sad, but trying to also support each other and figure out ways in terms of supporting the caregivers is key. And there are a lot of things out there, but I think that the challenge is for a lot of caregivers is, first of all, navigating all these systems and finding people and to help you navigate that process can be really difficult. And somebody had put in the chat about older caregivers and trying to, figuring things out. It's complicated out there. So hopefully, by finding people that can help you maneuver through these sites is key. But those pillars of brain health, most of them don't cost a lot of money. So using those, and I feel like sometimes a broken record, all the things that what's good for your heart is good for your head is true. So, and even the AARP has programs on, you know, brain health and what kinds of things you can do. And there's so much out there in there. So I mean, it's all the same things that your doctors and nurses have been telling you for years of things to do.
Yeah, so before we turn it over to Catherine, who's going to be telling us about questions from our participants, just wanted to point out that there were several links that were posted. One, Kathy, you posted about non-pharmacological approaches, and then Dr. Hendricks posted something in response to a question about where you could get help in finding clinical trials. So that is posted in the chat. And at this point, I'm going to turn it over to Catherine and ask her about, you know, what are we hearing from our audience in terms of their questions?
I think you're muted.
You hear me?
Yep,
Yeah,
you're on.
Thank you.
Okay, sorry, lost you for some reason. I have a question that I think is appropriate for either Dr. Hendricks or Dr. Potter or Dr. Raffi, so I'll let you fight amongst yourselves as to who wants to take it. But the question is APP a diagnostic biomarker, or does it cause Alzheimer's?
I'll tackle that. So it's not a diagnostic biomarker. The amyloid precursor protein is a protein that we all have, and the enzyme there are enzymes that will clip that protein and form the amyloid beta peptides that go on to form the plaques. So I would say that it's associated with Alzheimer's disease. The actual biomarkers of Alzheimer's disease are the peptides that are the result of the processing of the amyloid precursor protein, not the APP itself. But I think maybe the confusion is that we know that people with Down syndrome have 3 copies of the amyloid precursor protein gene, because that gene exists on chromosome 21. Therefore, they have more APP, the amyloid protein, or precursor protein. And as a result, that's what is believed to be the reason that people with Down syndrome get Alzheimer's disease at a much higher rate and at a younger age of onset. So that's maybe a nuanced question to that, or nuanced answer to that question, but that's just try to lay out the biology, the basic biology of that. I don't know if
Thank you.
anybody wants to add.
Actually was a question that is somewhat related to something that you just said. We have an individual who asked if there's any data on the percentage of people with Down syndrome over the age of 50 who experience dementia of any kind.
So yeah, there is. So there's been some literature that shows that the average age of symptom onset, so 50-50, is about 55 years of age. There's some literature that shows by the age of 68, 90% of the Down syndrome population, roughly 90%, will have Alzheimer's dementia, that is symptoms of dementia, not just evidence of amyloid in the brain. So it is, so compare that to the general population. So the Alzheimer's Association estimates about, I think, 5.8 million Americans have Alzheimer's disease today. And so in the general population, that means ages 65 and above, when you most likely get that disease. And that 5.8 million Americans is roughly about 10 to 12% of the senior population above age of 65. So that's a huge increase of risk for Alzheimer's disease for Down syndrome compared to the general population. So that's why everyone on this panel is so concerned about Alzheimer's disease.
Thank you. I have a question that came in during Dr. Chicoine's presentation, so I'm going to throw this question in his direction. The question is, when you're making a diagnosis, what sort of physical exam signs would you expect? What sort of signs would you not expect?
So there's nothing really specifically on the physical exam to make the diagnosis of Alzheimer's disease. Primarily, again, looking for other changes that would suggest other causes, and maybe Seth can comment on that as well. We do see sometimes some of our individuals with Alzheimer's disease do have some almost Parkinsonian-like changes, but I would not say that's a common thing. Occasionally we'll see that, but nothing really specific on the exam that I would say is associated with Alzheimer's disease. It's really more of in many ways, a historical diagnosis, as well as using some of the screening tools that have been described. Seth, do you have any thoughts on that?
Well, absolutely. Yeah, the one thing I just do want to add, one thing that would be a red flag would be seizures. So in someone that has had Down syndrome, and whether they actually had seizures or not, but all of a sudden in later life, they all of a sudden started having seizures that they never really had before. That is a red flag for that might herald the onset of Alzheimer's. And then the seizures that they may have are what are called myoclonic, which is like a rapid quick jerk. That would be very concerning. So I think that into itself, with some suggestion of decline, and you're mentioning, Brian, some Parkinson, like a gait dysfunction. So there are some subtle things, but it is really based on a change of abilities. And I think that's a huge important thing for people that care and support people with Down syndrome, is getting the detailed information of life stories. And we in the NTG advocate for the early detection and screen of dementia, really, which is basically looking for a change in their abilities from one time point year or so before. What is the change, to document that a change has occurred? And that information drives the conversation that a change has occurred. So history, family members, caregivers who know the individual, the providers, the healthcare providers, they may never have met them before and they don't know who they are. So definitely it's important for the caregivers themselves to really explain graphically about the change, bringing photographs, bringing videos, and say, this is not who they used to be. And that would drive the question that a change has occurred, and the healthcare provider has to be open enough to look for, not, of course, Alzheimer's, and not be obvious, say it's got to be Alzheimer's, and look for all the other causes that it might be and not Alzheimer's.
Yeah, if I can just add to that, Seth, so the physical exam would in some ways just augment or confirm the history.
Right.
So really, I think of it more as a historical.
But
yes, if they're noticing gait changes, but typically I've gotten that from the history first. Incontinence, obviously, memory impairment, confusion, but all those things, again, are primarily obtained initially from the history, and then the physical exam can confirm them.
Thank you both. I have a question for Dr. Raffi. And
Dr. Raffi actually had to leave.
He had to leave. All right, then we will probably roll this over to either Dr. Hendricks or Dr. Potter. And the question is from an individual who has a daughter who is already enrolled in a biomarker study. And she asks, if we already know what biomarkers indicate Alzheimer's disease in the Down syndrome population, why should my daughter continue in a biomarker study, and why is NIA still funding that work?
Well, I can answer that to some extent. There are new biomarkers being studied every year that come up from the research. And therefore, collecting the blood samples from people with Down syndrome or typical people with Alzheimer's disease or pre-Alzheimer's disease is still incredibly valuable. And we really appreciate people who stay in those biomarker studies. Doesn't hurt, adds a lot to science. And in the end, those biomarkers may be able to tell us two things of great importance. One is, what is the precursor to the development of dementia? What biomarkers predict dementia? And the other, as we showed and others have shown in their clinical trials, some of these biomarkers are a very good measure of the efficacy, the success of the drug or treatment in the trial. So knowing these biomarkers is giving us great insights into disease in Alzheimer's, whether it be in the typical population or in people with Down syndrome.
Dr. Hendricks, were you going to add something?
Well, no, I think that was a great answer. The only thing I would say is that beside thanking you for your participation, one of the most important things to also look at is how people change as they age. The biomarkers may change. And probably the most important Alzheimer's disease study ever done, and it's still going, is a study called ADNI, Alzheimer's Disease Neuroimaging, that has been funded by the NIA and has been going on for over 10 years. And it's really just to look at people and their biomarkers, how people change as they age. And it's not just people who are getting sick and progressing to Alzheimer's disease that's important. It's also important to find the people who don't progress and learn what is different about them. And that can help us find new therapies and new treatments too. So all of that research is so critically important. So please, please, please stay in the study.
Yeah.
Dr.
Catherine,
Ezra, given the time, I'm going to send it back to you, but I just want to say we did have some other questions, and I did promise people in the Q&A box that I would, because they did have some good questions, I would send them on to our panelists, and if they are interested in answering them and getting those responses back to me, I will make sure those answers get back out to the whole group.
That's a great idea, Catherine. Thank you. And also it may shape future programming. We might do a part 2 as a follow-up to this. So I want to thank all our presenters and thank you all for attending. For more information specific to intellectual disability and dementia, please visit the NTG website. And please watch for announcements for upcoming webinars presented by NTG on this and related topics. And as a matter of fact, we do have an upcoming event, October 12th through October 15th. There will be online training, dementia capable care, adults with ID and dementia. This is an online workshop for which you can register. So thank you again for joining. Dr. Keller, as co-president of NTG, any final words?
Well, thank you, Lucy. And I first want to just thank you all the presenters, and you, Lucy, and Kathy and Catherine for supporting this, but of course, everyone who came on. Absolutely, we meant to put this presentation on as an update. It really couldn't fill in all the depth and details as much as we would like to, but really the important thing for everyone listening is things are absolutely going to change for assessment therapeutics today, tomorrow, and the next weeks and months and years to come. So what we knew then will be very different. So there is hope. It might be slow to come, not soon enough for some and others. But again, we really wanted to really put this out there. And again, thank you to our sponsoring organizations who are going to be working with us all the time. This is a group effort, friends. This is a group effort, and we're all in this. So again, thank you all very much.
Okay.